Hello, I'm Dr. Francesco Pedetta from Italy. I am a specialist in orthodontics and I have a private practice in Pisa. I'm here to introduce you my first video about modern orthodontics. I think that is about time nowadays to change the traditional way of thinking and making orthodontics. And this is especially due because there are so many new information that we have to move forward and understanding the new information and trying to see if there is a new method of diagnosis and treatment planning orthodontics. I know this is a quite important goal, a task difficult to reach, but what I think is that it's useful to share this information, and that's why I'm here for, especially with the students from all over the world, and also for colleagues and specialists in orthodontics and whoever actually is looking for the highest quality in orthodontics, but trying to keep it simple. And whenever I talk about simple, I'm not saying simpler, just simpler thing, like a shortcut, not at all. I actually would like to have the simplest method with the highest quality. The highest quality has to be the task for us as orthodontists, as professionals, and also the highest quality is due to our patients. That's why I'm trying to introduce you this new method that is called the new straight wire method. And actually I wrote a book that is edited from Quintessence, you can find there, New Straight Wire, in which all of this information are in. But now I like just to discuss, to make a little introduction to understand what I'm talking about, and if there really is this simple method to use for orthodontics. I have been graduated from Pratt University. That was a wonderful university in Philadelphia. This is Chansi Chang, the new director, who was there when I was studying there. And I have been exposed to a lot of special lecturers, special masters in orthodontics that really I loved. I can talk about Barney's Wayne, some of them are not here anymore. I'm talking about Norman Setrin, I'm talking about Robert Van Asdal, the dean of those days. I'm talking about Ronald Rudd, going, moving a little step forward toward modernity. I'm talking about Ronald Rudd, I'm talking about McLaughlin and all the others, and very important person in orthodontics. And I used to follow this traditional way of thinking orthodontics, and eventually somehow I was so lucky to meet this man that I think he still is the master in orthodontics. It's Larry Andrews. I think everybody talk with me knows that I think just he's a genius. And these are, the teachers that are taking orthodontics to the new level, step by step. Nowadays we are in the 2022, and it's about time to really think about what is out there to help us, and finally to help our patients. So this is the time we spent with Larry Andrews, and I think it's so unbelievable. And actually the people who can get through the sixth element of orofacial harmony, that is this philosophy of viewing, whoever can look deeply in this philosophy can have a lot of information, really a lot of new information, because I've seen that going teaching in different universities or just listening to the lecturers all over the world, I see that this information are not so well understood everywhere, and so they are not really into the new way of making orthodontics. That's why I'm here to explain you this new method. The new method is called the new straight wire, and you're gonna see that it's gonna be probably simple and clear. It's just an introduction So being an introduction has to be quick and simple. So I just want you to know that the 6 elements, this fine, incredible work that Larry Andrews and his son have done for the years, collecting all this incredible information and to organize them in a method themselves, their methods, is now taught in different universities, and I know Tim Tremont, who is teaching it, Norman Boucher in Philadelphia is teaching it, and here in Italy at the University of Torino, Tommaso Castroforio was so kind to let me introduce the method to the students. So I think the students are the most easy people to open up the mind, because their mind is not closed. Specialists I know, whoever follow a different philosophy, is going to be, for them, it's going to be a little difficult to get new information, really understanding them instead of fighting them. I can say that because I went through the same thing. I went through the same thing. As long as I met Larry Andrews, it took me some time to really understand what he was talking about. And I had to open up my mind and to free up a little space in my brain to let this information settle in, and then try not to reject them, but trying to see what was inside them. And this was the best thing I could do, because I think his 6 elements philosophy is probably the most complete and best philosophy all over the world right now for orthodontics. And I always look for the highest quality, and I'm talking about highest quality for diagnosis, that I think it is still the most important thing, even though a lot of people say that diagnosis is the most important thing, but then I see that diagnosis is not done with the highest quality level because of the information that you are putting on your diagnosis. So the information that Larry Andrews put in his diagnosis, it's unbelievable. The only thing, it's not so simple. It's not so simple actually, and there are something that I think we can figure out differently and organize differently, and in a simple but with the highest level quality method that is called straight wire. So first of all, I wrote this book for my colleagues and my students here in Italy, and then I was so glad that Quintessence wanted actually itself to publish in English. And so right now I'm receiving letters from all over the world asking about information about this method, trying to get more inside it, trying to get lectures, private lectures. I do private courses, but I think that the most important thing is to reach people all over the world, trying to share the information. There is no way that I have to keep all the information for myself or for few people, but I like to share them with the most amount of people possible, and maybe to discuss them or to see what people think about it. So, new straight wire, what this method is all about. I like this thing that has been written from somebody who has read the book, and he said actually it was very right when he said here, and that we were systematically calculate and plan the necessary tooth movement, the treatment plan, before treatment, following the same parameters for each and every patient, regardless of malocclusion. There are a few different things, very different from the traditional way of doing orthodontics. I've done orthodontics the right way for so many years, and then I had to change all my mindset. So first of all, it's an introductional video, so I want to just get inside it and to tell you what is the most important thing actually we have to do whenever we have to diagnose, and then to make the treatment plan for the patient. What is it? I used to do a lot of work before, but now I am very clear with this. The first thing to do is to understand two concepts. One is an aesthetic concept, is the glabella line. What I'm talking about, the glabella line, it's on my book, but the glabella line is nothing else than an aesthetic line that is perpendicular to Francoforte, or perpendicular also to the floor, we could say, but it's the perpendicular to the Francoforte horizontal and traced by the forehead. What I mean for that, it's a perpendicular line going from the forehead. And why this line is so important? It is very, very, very much important because this line tells you where the upper incisors should be on a patient face, okay? So actually it is very, very, very important and very easy to be drawn. It's just a line. So what is it? Why it's so important? Why there are so many methods for analyze the static of the face of the patient? Why? Well, I tell you, right now in the 2022, we are shifting orthodontics. We are not dealing anymore with fixing the posterior teeth first. That's what does it mean? Fixing class 2 in class 1, class 3 in class 1, more relationship, and then moving the other teeth. No, the best thing to do now is to focus on anterior teeth, because the anterior teeth are the aesthetic of your smile and the smile of the patient either. So we have to move our thinking in a way in which the aesthetic is most important, and if we can keep the best, so the highest quality level aesthetic for this patient, we have to go for it. So the first information I want to know exactly is where the upper incisor of my patient are comparing to the glabella line. A very easy line to be drawn. Because the face drives orthodontics, and orthodontics is mostly the position of the anterior teeth. So whenever you take in consideration these, and you can see here, a profile of a class 3 patient of mine, of course, that has been treated, but I would say has been diagnosis first and treatment plan then with the aesthetic line, with the glabella line, as a reference line for her. So we can see the profile, of course, and I'm not here just to show patient to say, look at my patient. No, not at all. This is something just to discuss with everybody. The important thing we have to figure out before starting the treatment, and also to make the right diagnosis. So, the profile it's present, and of course is present, but everything comes from what? This patient went through surgery, orthodontic surgery, and then orthodontics also, of course. But the position of the upper incisor that we were dealing with, were the upper incisor of the patient were farther back from the glabella line. So the glabella line is telling me, is telling also to the surgeon, please, trying to do something in which my upper incisor will end up the closest possible to my glabella line, because it's a personal line. It depends on the configuration of your forehead, and so it's a very unique for every single patient. Once you fix the upper teeth to the glabella line, you will have the highest quality profile for this patient. I'm not talking about beauty, of course. I'm talking about the harmony, as Larry Andrews always says, the harmony of the smile of this patient for his face. And the point is that we have to figure out the aesthetic line on the hard tissue, the teeth, not the soft tissue, upper lip, lower lip, chin. No, not at all. The first thing we have to do is to figure out when the patient is smiling, where are the upper teeth comparing to his forehead? Because this is the best thing, the highest quality you can provide for the aesthetic and the harmony of the patient face. So this first introduction, the first important concept is to have in mind, to keep in mind the glabellar line. This doesn't mean any more than that. The glabellar line will tell you where should be the upper incisor for the best harmony or the profile, the smiling profile of this patient. Doesn't tell you anything more. Doesn't tell you that you have to put the incisor over there, but you have to keep them the closest possible you can over there. So we are going very quickly through this introductional video, and then we will have a series of videos getting depth into it. But you know, I'm Italian, this is Leonardo da Vinci studies, and I'm so glad that it actually already had this line. So this line, the glabellar line, soft tissue glabellar line, is due to Leonardo da Vinci, and I'm using it. And also the Francoforte horizontal probably was already in his hands to study the profile and the proportion of the face of the patients. So the glabellar line is there from a lot of time ago. I know that, you know, these are just new information. A lot of people will say, will tell, and will think, as I was thinking either, the same way. Well, I do the aesthetic study in a different way. I'm using a different line. I know, I definitely know. There are a lot of different ways to analyzing the profile. I just try to keep it the highest quality information in the simplest way. And I know that we could go through soft tissue analysis instead of the position of the upper incisor analysis, that is hard tissue analysis in the profile. I like William Arnett, an incredible guy. I mean, these are, you know, the best guys we can learn from. And I'm glad I met him in Rome, and I know exactly, and I love the way he's thinking and the way he's doing his patients. But still, nowadays we have really to choose where we want to be, because soft tissue analysis, okay, soft tissue, upper lip, I know. Also, you also use a perpendicular line to the floor, to subnasale, to see where the upper lip, the lower lip, and the chin are. I know that, but you know, the soft tissue doesn't really tell you where the teeth will be in this patient, because even though the upper lip could be fine, according to Arnett, it is not fine at all according to the smile of the patient, because the upper incisor is farther away from the glabellar line that in my mind, I think it's like the static line of the smile of the patient. And this is, you know, if you take your patient and you try to figure out, you can see a lot of them with nice harmony in the profile, and then when they smile, they're not at all in harmony with the smile. So I quitted using the soft tissue analysis, and I went to the glabellar line. I used the glabellar line, and you know, a lot of people, a lot of students, you know, put a lot of effort in cephalometrics. You know, I used to teach cephalometrics at the University of Pennsylvania for the entire month on those years, back on those years when I was coming back after graduation, and I was teaching them all the different analyses, Downs, Ricketts, Tweed, McNamara, Biojar, but I think all of them, of course, because I had to teach them all the analysis. And I knew years by years that you know, the cephalometric analysis really, they were not telling us exactly things we had to do in the treatment plan. So there was this dyscrasia in between what I was doing and what I was obtaining. So I don't want anymore to get through this kind of analysis, angles and stuff that doesn't really tell me, and so in the final step doesn't even tell the patient what and where their teeth should belong. But in a very simple way, we can have this kind of analysis in which we have upper incisor, lower incisor, occlusal vein, and a couple of lines. Will tell you much more than all the other different analyses. So the glabellar line. Now we move to the second concept that I think they are the most important concept. These two concepts are the first step where you construct the diagnosis and you construct the treatment plan. And so it is very important to forget about all the other stuff that it make you go slow, make you go confusing, and eventually make you maybe sometimes making some errors that we don't know because it's not so simple. But we have to think about the second step the orthodontist has to think about, and actually is the second concept, but the most important one is overjet correction. So whenever I see a patient, I don't talk about anymore class 3, class 2, hyperdivergent, no, not at all. I'm looking about upper teeth, lower teeth, the overjet, and the glabellar line. And so the correction of the overjet is the most important thing that we have to think about. What I'm telling. Well, first of all, there is a connection in between overjet correction and glabellar line. That's the first point. I mean, I don't go correcting the overjet, by other reference line. I want to know where the glabellar line is before I take my decision. And of course, before I start moving teeth in my patient. So, of course, this is a normal class 2 with a huge overjet. How do I correct overjet? No, and everybody will talk, well, it depends on this, on that. No. First of all, depends on the glabellar line. Why? Why is that? Because let's suppose the glabellar line is right there where the upper incisor is in this patient. What does the glabellar line tell you? Tells you, okay, we have a class 2. Remember, Dr. Orthodontist, that the upper incisors is already in the best place. So please try to correct occlusion, to move your teeth without taking upper incisor away from the glabellar line. Or, what does it tell you? Eventually, if it is not possible to keep the upper incisor on the glabellar line, please choose the treatment plan in which the upper incisor move away from the glabellar line the less possible. So actually, it's starting telling you a lot of things. Please, trying to correct the occlusion, moving the lower teeth, not moving the upper teeth. And then you have to figure out how you can do it. Of course, whenever we correct overjet, so we are still focusing on the most important thing that we have to think about when we start the diagnosis and treatment planning on the patient, this overjet correction. Of course, I could do like that. I take upper incisor and I bring it back by a movement, I would say tipping and body movement. We will talk about those things because there are so many important things to talk about when we talk about movement of the teeth. But I don't want to go right now on those things. We will go in different videos in the future on my channel. But right now the overjet has been corrected this way. Let's say the upper incisor goes back to the lower incisor. That's a correction. Of course, we are starting from the frontal teeth. As I told you already, and like a lot of people are doing already, also in different methods that are using this different philosophy, they know the importance of the frontal teeth, so they kind of put frontal teeth at the center of the decision. So right now, we have think about retracting upper incisors, and look at what happened when you start from the front, when instead of starting from the back posterior teeth. Whenever you move the upper teeth in visualizing your treatment planning, your objective treatment planning, that I'm visualizing it before I even start the patient. So I move the teeth on my symphonometrics and I see how much space you need to put the upper incisors back. And then, of course, I have to move all the other teeth back in order to accommodate the upper incisor in the position I decide to choose as my position for the patient. So we don't start from the upper teeth, the molars, We don't say, okay, I put molars in class 1 relationship, the premolars in class 1 relationship, the canine in class 1 relationship, and then I close the space of the upper incisor. No, because this is focusing on posterior occlusion the traditional way everybody was taught about. No. So this is a way we could choose. But this example of correcting the overjet in this patient can also be the opposite. Let's say I leave the upper incisor where it is, and I move the lower incisor forward in order to correct the overjet. Still I have a corrected overjet. It's not a perfect overjet, it's a corrected overjet. I have to figure out how to correct the overjet. I don't want to correct it putting in the perfect inclination of the tooth, but I want to keep in my mind the upper incisor closest possible to the glabellar line, and then moving the lower teeth if I can, because I want to stay on the standard, highest standard quality orthodontics and diagnosis for my patient. So this can also be a choice for my patient, an option 2, okay? It depends on the glabellar line. So the position of the teeth, frontal teeth, upper and lower, depends on the position on the glabellar line. Doesn't depend on my opinion. Doesn't depend on the inclination of the tooth. Well, it will be affected by the inclination of the tooth, and we will see now in the following slides. But actually, it's the most thing we have to figure out is how to keep the upper incisor the closest possible to the glabellar line. Because if the glabellar line is here, I don't want to move the lower incisor anymore that way. Because, I mean, this will mean that the upper incisor, they are too much forward comparing to the glabellar line, and I don't like this option for my patient. So, if the glabellar line touch the upper incisor once I corrected my overjet, this is my goal for this patient, and I will explain to the patient. I will tell, listen, we have different options, but if I want to keep your upper incisor in the best, highest quality position for the harmony, and then for the aesthetics of your spine, I have to leave it where it is, and then I have to move or the other teeth. In this situation, I will choose this retraction of upper incisor, because I know if I retract the upper incisor, I can keep it right on the glabellar line. Okay? So, it is an introductional video, but we are already there thinking about where you really have to fight to understand the diagnosis and then to organize your treatment plan. The second concept is that the incisor, you cannot move the incisor where you want. You cannot move lower incisor 5 millimeters away from where they are in the patient, probably. So, actually, the glabellar line is an important information. The other information is to understand the position that you start with the incisor. And just a few slides, 2 or 3, and then we are over with this first video, to let you understand that also with implants, the dentists know exactly this, that sometimes they like to tilt the implant a little forward or a little lingually or labially, just because the occlusion will end up in the best way. So they know they can tilt it. And the same way we can tilt the lower incisor or the upper incisor forward and back. But we cannot tilt it so much. There is a limit. And talking about the limit, I know that somebody will tell you, who said that the limit is 2 millimeters, like I said, like Larry Andrews says, like other people says. But there is not such a, but it's a geometrical thinking, because if you keep in mind this is an implant centered in the center of the alveolar bone of the patient, we know exactly now with the combing there is not much bone in front on the lingual or the lower incisor at all. It's less than 1 millimeter if a millimeter is there, or less than that. So we cannot move the implants, forward or back in order to organize better the occlusion, because then it goes out of the center where it should be, it should belong. But you can tilt it a little bit, and geometrically you can try with a software for geometric movement of figures that more than 2 millimeter tilting buccally or lingually you shouldn't go. So there is also a limit. I mean, I'm an orthodontist. I know the limit of movement of the lower and upper incisors comparing to their best position in the center of their vertebra. So this is valid also for, of course, tilting back, retracting lingually the lower incisor. I can go a couple of millimeters tilting back. So what does it mean, all of this? First of all, it's all come from the incredible work, the position of the lower incisor, the incredible work of Larry Andrews in his 6-element orthodontic philosophy, in which he tells you exactly this information. The point is keeping this information and putting in the right space to organize your treatment plan and the diagnosis. So, of course, whenever you have to decide how you can correct the overjet, that is the first step in my diagnosis and treatment plan. You have to measure if you can move the lower incisor in the direction or the upper incisor in the direction you want to correct the overjet. And if you are able to do that, because if you move them too much, then you end up with a lot of problems that you don't want. So this is the beginning of this trip in the method, the new straight wire method. And we are focused on what? We are focused on overjet, the most important thing we have to think about when we start planning the patient, and the glabellar line as two useful things to start with. And then we can go back and explain all the other in new videos. I hope you enjoy the video. Stay on the channel. Please subscribe the channel, and let's talk about modern orthodontics in 2022. Bye bye.